Hello, everyone. We can move on to the next talk. Our next speaker is Dr. Andrew Beaumart. He's the medical director at Rogerson Kidney Center, Manhattan. He's an instructor of medicine at Weill Cornell and an assistant attending physician at New York Presbyterian Hospital. He did his education and training at Mount Sinai School of Medicine. Dr. Beaumart is one of the founders of the Rogerson PEAK program, which is a program designed to educate, counsel, and manage patients with advanced chronic kidney disease, stage 4 and 5. Today, Dr. Beaumart is going to be talking to us about CKD PEAK program.
Right. Good morning, everybody. I'm Andrew Beaumart, as she said. Thank you to the organizers for inviting me. I'm one of the nephrologists at Rogerson Institute. Just for those who don't know about Rogerson, we're a large nephrology practice and dialysis center. We're one of the larger non-LDO dialysis centers with units throughout New York City in 4 of the 5 boroughs. And we're also a large nephrology practice, focusing on all nephrology things, and particularly, for the purpose of this talk, on chronic kidney disease, and for this talk, specifically, advanced chronic kidney disease. So the title of my talk is Multidisciplinary Clinics in the Management of Advanced Chronic Kidney Disease. And so I'm going to talk a little bit about multidisciplinary clinics in general, and then I'm going to introduce our program, the PEAK program, and that stands for Program of Education and Counseling on Kidney Disease to kidney disease patients. So let's begin the talk. So multidisciplinary clinics is actually part of a KDIGO recommendation about team-based integrated care. And just to read through this practice point from KDIGO, it's enable access to a patient-centered multidisciplinary care team consisting of dietary counseling, medication management, education, and counseling about different kidney replacement therapy modalities, transplant options, dialysis access surgery, and ethical, psychological, and social care for people with chronic kidney disease. And you can see, the pyramid, whereby when the risk goes up, particularly in what would be considered CKD 3B or 4, is when you want to introduce this multidisciplinary care team. And that's, perhaps different than the traditional educational model, which is really to introduce just modality teaching, let's say at CKD 5, or GFR strictly less than 20. So the idea is to be a little more upstream of that, and that's one of the main points of this discussion. So chronic kidney disease, the burden and the challenges, this is something that most of us know. It's a huge burden. Just to throw out some numbers, big numbers, 37 million adults in the United States are considered to have chronic kidney disease, and many of those are undiagnosed. A lot of dollars involved in taking care of people with kidney disease. Medicare, leaving aside all the other payers, spends more than $130 billion a year on patients with kidney disease. Annual Medicare costs, $23,000 to take care of a CKD patient, $90,000 for a dialysis patient, and a frequently talked about number, it's 7% of the Medicare budget goes to taking care of dialysis patients. The challenges, most of us know these. Low home dialysis rates, albeit improving across the country. Not enough preemptive kidney transplantation. Hospitalization for initial dialysis. So how can we avoid crash starts? Catheters for vascular access, huge problem. Starting dialysis sooner than necessary, and what cost to patients and to healthcare dollars does that mean? And then high mortality and hospitalization rates, especially in that first year, that transition year. So this is just to bring home the point once again that it's costly to the patients, costly to society. Just that first year alone, total Medicare cost $238,000 a patient. Crash starts also contribute up to $70,000 in excess commercial payer spending. Just to make the point that there's a lot of dollars involved in a lot of ways we can make improvement. And the reason for really pointing this out is it has to make sense to us as providers. It also has to make sense to our payers. So this is to introduce what is a multidisciplinary care clinic for advanced CKD. And when I first started, being involved with our multidisciplinary program and was first getting it going, it occurred to, first I was involved more as a dialysis provider. And in the dialysis unit, at least the ideal is to be a multidisciplinary clinic. Social workers, nurses, of course, technicians, dietitians, and of course, the medical provider, doctor, NPPA. Why not bring this more upstream? And so that is the idea. And just to make some points, the idea is that these patients deserve, and also it's good care, that it's bigger than just one doctor sitting in a room with a CKD 4 or 5 patient and going through things. So it's bigger than the traditional one provider, one patient model. And so the idea is multiple providers taking care of a patient and also including the family when we're able. So what is the multidisciplinary team? It could take different forms in different places, but some of the players, so to speak, on the team could be nurse practitioner, a nurse educator, a counselor, coordinator, a dietitian, social worker, peer mentors, data scientists can be very important in being able to collect the data and see what you're doing. Collaborating doctors, of course. Palliative care specialists, and peer mentors I wrote down twice, but perhaps unconsciously on purpose to make the point. So anyway, so what kind of role can these different team members have? And this is just to point out some ideas. So a dietitian could be there to review blood work, somewhat how often dietitians do in the dialysis unit. Talk about achieving guidelines for bone mineral, CKD, MBD, evaluate weight, discuss dietary changes, of course, what we talked about just before, food as medicine. Social workers, a lot about coping. How do patients cope with the diagnosis of CKD, and how does that interfere a barrier to better outcomes? What are the lifestyle consequences? What is the impact on family caregivers? Of course, a lot of patients worry about finances, who's going to pay for this or that, medicine, care, so insurance counseling. A pharmacist can be a player on the team. A lot of medications these patients are on, a lot of polypharmacy. How can that all be monitored? Supporting medication compliance. Monitoring immunizations, another important thing for our patients. So this is just to mention that multidisciplinary programs in this area have been around. One of the ones that was very successful, kind of in our backyard at North Shore, Dr. Fishbane was in charge of this program, and they used nurse managers to provide coordination support for doctors. And this is actually a randomized control study, 130 patients with a follow-up of 18 months. And they had good outcomes, improved hospitalization rates, increased usage of PD, and decreased inpatient starts. All the things we would want. So in 2015, myself and some colleagues got together and created our program. We came up with the acronym PEAK, Patient Education, Counseling Coordination for Advanced Kidney Disease Program. And the idea is to find and focus on high-risk patients and have them be cared for by a multidisciplinary team, and then have that multidisciplinary team collaborate in the patient care. So emphasis on education and counseling on options for renal replacement therapy is a big part of the program. And then another big part of the program is QAPI. Are we doing the best we can do? And for that, you need numbers, you need data, you need to be able to collect data. And we'll talk a little bit more about that. So this is kind of a schematic diagram of how it works. We have a large nephrology practice. The primary nephrologist puts in a referral to our program, and they're seen initially by a nurse practitioner and social worker. They then get into that circle where they're meeting all the other different team members. And over time, for us, the team members have changed, and at different times. And so they enter the circle: nutritionist, wellness ambassador, which is what we call our peer mentor program, nurse educator, clinical psychologist, behavioral counselor. And then, when appropriate, they're referred to for surgical access planning or transplant referral. So these are our results. 2015 to 2021 is the data I'll talk about here. And we had 579 patients enter into the program over that 6-year period. 319 of them went on to need renal replacement therapy. And here are our results. Preemptive transplant rates of 12.5%. Peritoneal dialysis rates of 19%. Home hemodialysis rates of 5%. And 63% went into in-center hemodialysis. And this is just to show how our outcomes compare to national outcomes. using some of the USRDS data, and in one case, Kings County data, where we are now. So started home dialysis. In that period of time, 24% of our patients started home dialysis. And just to bring it home, in 2019, 2.5% of patients in Kings County were on home dialysis. I don't have the up-to-date data. Perhaps you could tell me. I'm hoping that's better now. So started dialysis without a tunnel dialysis catheter. We were able to achieve 54%. USRDS national average or national numbers, 15% of patients start dialysis without a tunnel dialysis catheter. Preemptive transplantation, we were able to achieve 12.5%, and compared to national, 3.5%. So and this is just to show how we increased home dialysis over time. You can see our rates increasing. 2021, we had really good data, up to 43% of patients choosing home dialysis. And things were a little bit wonky during the COVID years, as they were for everybody. So one of the main things we focus on, and this is optimal transition to dialysis, the optimal start, which is actually an outcome that the Kidney Care Choices model, which some of you may know about, chose as one of their outcomes. And the Kidney Care Choices model is one of the alternative payment systems, value-based payment systems that Medicare has set up to, for this very purpose, to achieve better transitions. And it's a payment model that includes both CKD care and ESRD care. So anyway, the definition of optimal transition to ESRD, ESKD is starting in-center hemodialysis as an outpatient, as opposed to a crash start in the hospital with a fistula graft, or receiving home dialysis, or getting a preemptive kidney transplant. So these were our outcomes. Just focusing on the upper left, our transitional, our optimal starts numbers. Very early on, we were able to achieve very good numbers, 50, 60%, and throughout the course of our existence, we've been able to keep those numbers stable. Home dialysis rates have consistently gone up for us, and thankfully, particularly over the last few years, across the country. This is just to point out that we've been able to exceed national averages across different demographics in terms of race and ethnicity, different demographics in terms of what type of insurance patients had. So across every type of demographic, our program has been able to improve or be better than the other case. So one of the important things that we realized right away to do this program is we needed to be able to collect data. We needed to know how we were doing and be able to share information across the multidisciplinary team, and ideally across hospital system in general. And one of the things we found is that EMRs are really not designed to look at this, to look at transition to care, look at advanced CKD 4-5 from a multidisciplinary care perspective. So we went, our our systems changed, over time. Rogosin is an affiliate of New York Presbyterian, so along with New York Presbyterian, as they entered the world of Epic, so did we. And so we've worked a lot with Epic to try to create a system that works for us. And finding out that they didn't have it, so we had to build it. And this is just, something we created. It's just a way we can keep the data. It's called a smart form in Epic, but that not really pertinent. And this is a way for us to record the data. Is the patient a transplant candidate? Have they gone further initial evaluation? Are they on the waiting list? Do they have a donor? Have they chosen a preferred renal replacement therapy? Have they gone for surgical evaluation, access evaluation? Do they have access already established? And if it's a vascular access, is it mature? And similarly, part of the form is, what have the outcomes be? What have the outcomes become? And then we've also used the EMR to create reports, to help guide who we can focus on the most, who we could put all our resources in. And one of the things we've incorporated into Epic is the use of the kidney failure risk equation, so we could see the patients with the highest risk. So a few more slides. And then we have these reports. We go through it we have our weekly care meeting with all the team players, and we're able to go through each patient and see where patients are in their care and who to give focus to. So this is just, again, a summary of what we've been able to achieve to date, and some of the numbers that estimates of how much this can save payers, because ultimately we would love to have payers be able to reimburse accordingly. Now, this is really the last slide, and this goes to that last statement. How can we make payers reimburse us for all the care we're providing? And things seem to be going in the right direction. The Kidney Care Choices model, which I mentioned before, is meant to reward teams, providers that are providing CKD and not just ESRD care. Within the model, how are the different programs achieving or trying to achieve success? Some are using multidisciplinary care teams. Some are using strictly coordination services. Will we be able to distinguish in a more granular way which is more successful? Something to consider. So then, really, this is my last comment is, I think the collaboration with all the different disciplines for all of us, particularly, I'll speak for myself, has been good for job satisfaction, good for morale. It's really nice to work with others toward helping patients. Happy doctors, happy staff, happy patients. So thank you for your time.
We'll save the questions for the end. Our next speaker is Dr. Vincent Carcillo. Dr. Carcillo has practiced nephrology since 2004 with New York Nephrology. His nephrology fellowship training was completed at Albert Einstein Medical Center. He is an assistant professor of medicine at Albany Medical College. He has been a longtime managing partner for his private practice. He is a mentor for practices engaging in home therapy growth. He recognizes the importance of collaboration between medicine and industry and has developed a successful, independent, value-based care program in partnership with a regional health plan. Today, his talk is going to be on seamless peritoneal dialysis and breaking down barriers.
Hello, everyone, and thank you so much for having me today. Thanks to the organizers. Thanks for everyone for coming out today. I'm very grateful to be with you. And so I will get started by talking about a program that we started in 2016 we call it Seamless PD. And I'll tell you why we started that program and what it's all about. But I'm also going to talk a little bit about home dialysis in general, why we're talking so much about home dialysis now, what some of the barriers are to improving our rates of home dialysis, and then some potentially innovative solutions, because we're going to need different models, we're going to need different organizational structures if we're really going to move forward in an innovative way. So why home, why now? And so we've been talking about this now for a few years, but this is actually Secretary Azar during the first Trump administration, and at that time, home dialysis was a new focus for incentivization. And we've already heard some of these numbers, but we know prevalent ESRD is rising. There is a huge cost to that as far as Medicare goes. And we know that there's a cost savings, and we've seen some of that data already today for home dialysis versus in-center. And so home dialysis, we can have different directions that we may go, right? We have the options of home hemodialysis, which is an excellent choice for patients, especially with a working access. There are some pros and cons to that. We also have peritoneal dialysis, and with peritoneal dialysis, and I'm going to focus a little bit more on PD, we have a couple of ways that we can do that. We can do traditional peritoneal dialysis, which requires a waiting period after the catheter is placed. We can do urgent start peritoneal dialysis, where we start dialysis right away after the catheter is placed, but with some caveats to that. And then I'll talk a little bit about the program that we started that we call Seamless, that maybe overcomes some of the barriers that we encounter with urgent start PD. So, well, why PD versus IHD in general? Why don't we just stick with what we've traditionally done? Well, we know in-center hemodialysis traditionally has been incentivized. We built dialysis units in the 80s and 90s around in-center dialysis. We didn't build them to do peritoneal dialysis, and most of you have been in dialysis units, and you know there's a home dialysis training room somewhere in the back, right? And so we weren't built as a profession to do home dialysis, and so that is why for a modality that's been around for decades, that we're talking about it now as if this is something that's new. But is there mortality data? Well, there's no good randomized trials here. Baxter attempted in the 1990s, but that trial was stopped early due to low recruitment. Another trial out of the Netherlands, they attempted to randomize 738 patients, but also stopped early. After informed consent, only 38 patients agreed to be randomized, and 20 chose PD. So what do we get from all that? Well, what I get from that is that in a society where one really has free choice, this kind of study is likely never going to be done. And when informed about their options, patients actually want to make a choice. And so I think we've been hearing that as a theme, and we'll talk about that, I'll talk about that more in my talk, where we're going to be shifting away, and we need to shift our models away from the doctor being the center of healthcare and the hospital being the center of healthcare to the patient being the customer of healthcare. And so looking at some more data, kind of going back and forth to make our decision from an informed way, about whether or not we should be doing this. Let's look at some observational cohort studies. Well, no survival advantage at 60 months, but you can see that there is some separation in the first year. Now, that advantage changes over time, and it's impacted by age and comorbidities. What about in other countries? Well, that separation is similar if you look at Canadian data as well as Northern European and Australian data. So how about a retrospective cohort study? And here's a study from 2018. All the patients developing end-stage renal disease between a significant number of years at any of 7 regional centers in Ontario, Canada. We'll kind of skip ahead there. All the incident patients with ESRD, PD was associated with a lower risk of death in that study. So there is some data or some evidence that we're at least not doing patients any harm by going with this modality. What about heart failure? Well, you can see here, peritoneal dialysis does have some advantages over in-center therapy as far as the probability of heart failure, and we know that there is some transplant-related data out there as well, showing, at least in some studies, lower risk of death and lower risk of graft failure. So how about a study from the American Journal of Managed Care? I'm sure that's on all of your coffee tables. And so, but looking at a study from 2009 and claims data from 85 U.S. healthcare plans, you can see that after looking at 14 million lives, there was a significant cost benefit to patients going on peritoneal dialysis versus their counterparts on hemo. So barriers to home therapy starts. We heard a little bit, we heard a significant amount in the last presentation about crashes to dialysis. This is a big problem. And so I've talked to a lot of groups about home therapies and home therapies growth and barriers to care. And if you'd been with me on all those talks and all the question sessions afterwards, there are a lot of barriers. And their barriers are different in different places. In some areas, we can't get a patient cleared from cardiology. In other places, well, we can't get a surgeon that does a good job putting PD catheters, or we don't have a surgeon that will take care of those PD catheters once they're in. There are a lot of barriers. But one of the barriers that we never really point out is the one that's staring at us in the mirror, right? Too many of our patients crash into dialysis, and that's not a cardiology problem. That is not a surgical problem. That is a problem that happens upstream in chronic kidney disease management. We don't do a good enough job upstream. And so we need better organization, like the program we just heard about, and education about modalities and options for dialysis. We need communication with our dialysis units so that we have seamless integration for our starts. And obviously, we need to work together with colleagues to make all of this happen. So unfortunately, in today's medicine, we work in silos, right? We may have many partners, but we don't work with them during the day. We work with our patients in our kind of silo throughout the day. And so we do need to find ways to work together. I won't spend too much time on this because we've seen some of this data, but we don't do a good job right now. We have to be honest about that. If 2/3 of our patients are crashing into dialysis, that's not a dialysis unit's responsibility, which is what we focus on in the QAPI meetings. Do we have good enough communication with surgeons? Are we getting early referrals for dialysis access? Well, if we're talking about that once a patient is sitting in a chair with a catheter who just spent the last 2 weeks in the hospital, we really missed the point. 80% have no access, as we saw, for initiation. Patients are often unaware of their choices, and they suffer the morbidities of hemodialysis catheters and experience, on average, 10 to 14 days of hospitalization related to those crash starts. So let's get back to peritoneal dialysis and how we do that, right? So in the best case scenario, traditionally, we place laparoscopically a Tinkoff catheter. That catheter heals over 2 weeks, and then the patient begins that training period, which oftentimes takes about a week at the dialysis unit. We can place a tunneled HD catheter, which unfortunately happens way too often, or we can put a PD catheter in, generally the same way that we do it across the country, which is that laparoscopic approach with a Tinkoff catheter, and we can do exchanges right away. but those exchanges need to be supine for about 2 weeks with low volume. So our urgent start PD experience, honestly, in the literature is not great. And so you can see some of the data here in that first study from 2017. Leaks were significantly higher in the first group, and in that second 2018 data, 10% of the patients had leaks and 10% had peritonitis within the first 90 days. But the conclusion was that this was an appropriate start for unplanned dialysis. Now, you have to start somewhere, right? And so if we want to get more patients onto peritoneal dialysis, at some point, maybe you have to take some risks to do that. But I don't want to be one of those 10% of patients that leaks and gets peritonitis as I start a new therapy. So then that begs the question whether or not our laparoscopic versus an open surgical technique approach is lacking. Well, what do our guidelines tell us? And so this is ISPD guidelines, and you can see guidelines written by Dr. Crabtree suggest that if a PD catheter is placed, that we do wait those 2 weeks to use that with full volumes. If we use it before that, we should be using low volume exchanges. And there aren't any controlled trials comparing laparoscopy with open surgical placement. And so what do we do with that? So to me, honestly, that wasn't good enough. And I was fortunate enough years ago, because we were struggling with vascular access in our practice, we did what I was talking about earlier. We looked in the mirror and we said, we're responsible for this, and so we need help. And so we hired a surgeon and made him a partner in our practice, made him a partner in vascular access and peritoneal dialysis access so that we could have one team, again, starting to scratch away at putting the patient at the center of care rather than just putting what is best for our group at the center of care. And so one of the benefits of that was that I had a surgeon right in the office next to mine. And so one day, passing each other in the hallway, and his name is Michael Galicchio, I said, Michael, what I really need is a PD catheter that I can use the same day or the next day. Just like I put in a tunneled hemodialysis catheter and I can use it right away, I want a PD catheter that I can use right away. And he said, so you mean like for urgent start? And I said, no, I'm not having good experience with urgent start. Most of my patients have congestive heart failure. They can't lay supine for 2 weeks. I only have one room at my clinic to train patients, and now that room is going to be blocked up for 2 weeks and I can't train patients. And I've got a lot of problems. And so I need your help. And so he said to me, can you get me a patient that's ready to go to the OR tomorrow? So I thought about that for a minute. And so round and round we went for a few weeks before we came up with what we thought was a legitimate plan. And so that required some of the things that I spoke to before. We had to reach out to colleagues. We had to reach out to cardiology and say, hey, we have an idea for a new program. Can we get patients cleared right away? Surprisingly enough, they said yes, absolutely. It was amazing to me when we actually spoke with our colleagues how agreeable that they were to something new. And so our goal was to get patients home quickly without the need for those supine exchanges. Now, initially, what I had envisioned for this was the crashes. I thought that this would be focused on patients who show up in the ER, who've missed a few visits, and then didn't feel good and called 911 and showed up in the emergency room, and then our traditional dogma is put in a catheter, admit them for a few treatments, find them a spot in the community, and then what happens later on, maybe we'll talk to them about home therapies. Maybe a month has gone by at that point. But what else happens, right? The patient gets admitted to the hospital, and so maybe they spend a day or so waiting for interventional radiology to place a catheter. We talk a lot about patient experience. What is that experience like? Patient gets that catheter, and maybe it doesn't happen late into the day, so they don't get dialysis to the next day, and then they roll into our inpatient dialysis room. Now, many of you may be working at different hospitals with different inpatient dialysis, but I bet you none of them are great because this is not a high funding source for hospitals, and so these rooms are usually underfunded, relatively small, relatively cramped, and so this is your first dialysis treatment, and you're in a bed next to someone who just had a fresh amputation and a 90-year-old who's coughing with pneumonia, and you look around that room and you said, oh my God, this is my life now. So I can't kind of overstate what that terrible experience is like in starting in the hospital. And so I thought that this program would affect those patients the most. What I realized was that there were plenty of patients who were crashing into our office. And we found that we had a culture within the office that that same patient maybe who missed the treatment or missed a visit or two that came in with a potassium of 5.7, and the husband is saying that, well, you know, my wife has lost 10 pounds in the last month. Many times that patient would be sent to the ER for a catheter and the same experience that I just mentioned, which is very unfortunate. So this is a choice for patients who needed dialysis within 24 to 48 hours that we wanted to give an option for home therapies for. So what we needed to do was provide an integrated approach. We wanted to create the most comfortable patient experience, and we wanted to improve entry into dialysis with fewer missed work days and certainly fewer hospitalization days. And again, wanting to make the patient the center of this program. And so it starts with the physician-patient encounter, whether or not that is in the office or in the emergency room. Enhanced education, again, I can't overstate how important this is, because we did not want to feel in any way that we were influencing this decision or that we were forcing patients into home dialysis. I mentioned in one of the early slides, when patients have a choice, they like to make it. And so we wanted to provide that education, and we were able to do that, again, with communication. We were able to get educators into the emergency room, into hospital rooms, and even on the weekends, even on Sundays. And so those kinds of relationships allowed us to get proper education, then surgical consultation, cardiology clearance. I mentioned that before. We've had wonderful response from our cardiology colleagues. I can't even say enough how grateful I am. They will clear patients at their urgent care cardiology chest pain clinics, and in any way are very helpful to us. An innovative surgical technique that you'll hear about in the next talk, and then that patient is straight to home training. So imagine the difference between the experience that I just mentioned and the patient who we see in the office, who we say, you're going to need to stay for a little while today. We're going to get the educator here. The educator meets with that patient that day. The patient gets cleared. They go to the OR the next day. And the third day, they're in the clinic, not supine, but with a cup of coffee in their hand, doing full volume upright exchanges. That is the goal, and that is what we thought of by putting the patient at the center. And so a little bit, and I've kind of been alluding to some of the differences already. Urgent start many times is abandoned for lack of education and coordination. We talked about integrated care. Decreased length of stay was a big part of what we set out to do, and then what we saw we were able to do, which then improved our relationships with both hospitals, payers, and dialysis units. And again, patients were able to immediately train. Most of them within 24 to 48 hours were in our center, and out of that center within, sometimes 5 days, between 5 and 8 days, and then sometimes back to work. So here are some of our measurables. We've had over 100 patients through the program since 2016. Dr. Glitchio has not had any significant catheter leaks. We've had one episode of peritonitis. We've been able to decrease length of stay and decrease hospitalizations in general. Those patients have been able to train with full volume and upright exchanges. So did we cherry pick patients? You can see here we have a significant percentage of our patients over the age of 70, many with significantly higher BMIs and Charleston Comorbidity Index. Obviously, we know how sick our patients are. I'm just going to give you a few case vignettes. I'm not sure where I am on time, and so I'll run through these with you. This was actually the first patient we did. And so we did not actually set out to do a formal research study. We just thought that we wanted to do what we thought was right for patients. If you were doing a formal research study, this is not the first patient that you would want to come through your study. A 59-year-old female with severe systemic sclerosis. This was actually a patient of one of my partners who called me up and said, I heard you're working on something for an urgent start PD. Can you see my patient? And so she had deteriorating GFR, mild hyperkalemia, similar to what I was talking about earlier. Rheumatology had refused for her to have an AV fistula because they thought it would never heal. And so traditionally, she'd be the person who's stuck with a hemodialysis catheter forever. And this is actually her and her husband, Mike. You know, we don't talk enough about how personal this is to us. And so turns out Mike was my kid's bus driver at the time. And you can see the patient's fingers very, very contracted. She was not able to do any of the work of her exchanges herself. So traditionally, not what we would consider as an excellent PD candidate. So, well, before I get into the next case, I'll tell you how she did. So she was on PD for 5 years. She had 1 hospitalization for new onset atrial fibrillation. She not one time had peritonitis. She was able to start PD right away. And I'll tell you, we did have to bite our lip the first time we went through this. Because when she got to the clinic, the nurse called me and said, are you sure you want me to fill her with 2 liters? Because she just had her PD catheter yesterday. And I said, yes, that is the plan. An hour later, she called me and said, well, she's not draining. What do you want us to do now? So one of the unintended consequences, I think, as we move forward with innovation is that once you open a door, you find yourself in a room with more doors. And so in a patient who got a PD catheter yesterday, you haven't had time to do bowel prep. And so she was a bit constipated, and she didn't drain. And so I ended up getting Dr. Glitcho involved, and he said, if she doesn't drain, stand her up, and if she leaks, it's on me. They stood her up, she drained, and 5 years later, she was still on PD. So really happy about the way that worked out for her. And here's another case. This is a young gentleman, someone who we would consider traditionally a good candidate for peritoneal dialysis. Known hypertensive nephrosclerosis, hadn't been to the office in a year. PCP drew labs, his creatinine was 11. He was told, emergently, you need to get to the hospital or you're going to die. And so he did. When I met him, he had his head down, very depressed. He had been living in his mother's basement. And so we got him some education right then and there in the hospital. This was on a weekend. Cardiology cleared him. We got labs. We got him discharged. Dr. Glitcho saw him. The next day, he had Missouri catheter placement through Dr. Glitcho's technique. And within 36 hours, he trained. I'll move on to one more case, I think, with you. And this one, I think, is interesting to me. And again, these are patients of mine, so I care deeply about these cases and about these people. And so we've heard at our clinics a lot about in-center to home conversions. And what we often talk about in the clinics as well, and we're seeing some calls come out to patients about PD to HHD transitions in an effort to keep patients at home, which I think is a good effort. But I think that there should be fluidity between home dialysis modalities, and here's an example of how that might happen. So here's a gentleman who had been on home hemodialysis. He has a fistula in his arm. He'd been on HHD for 2 years, awaiting heart transplant for cardiomyopathy. He lived about an hour and a half away from my unit, and he had what we would consider a bad day. He stuck that fistula about 15 times, and he had a massive hematoma over it. So we brought him in. None of our expert cannulators thought there was a chance that we could get needles in there. So again, old dogma versus innovative thinking. What would we traditionally do with him? You put a dialysis catheter, you bring him in center for a while till the hematoma resolves, and then you get him back on HHD. Well, he was a very intelligent patient and also a very nervous patient. And he called his transplant center, and the transplant center told him that if he got a hemodialysis catheter, that he would be off the list, at least temporarily. And so that was not acceptable for him. So I mentioned the wonderful relationship we had with cardiology. We made one phone call. He was cleared that day. As sick as he was with the severity of his heart disease, he was cleared that day. Dr. Galicchio took him to the OR. We put a seamless PD catheter in him. He trained in 5 days and was home, did PD for about a month until his hematoma resolved, and then we got him back on HHD, which was his modality of choice. So I think that we can, with open minds, have fluidity between our home therapies modality. And so really it's old dogma versus new. And I think we're hearing that as a theme throughout the presentations today, that we need to do things differently. We need to be organized differently. We have to have different designs with patient as the customer and as the center of our care model. So quickly now, and I'll finish up with just these last couple of slides. This is what we were able to do at just one center with a program like this. We were able to decrease the amount of training days that it took because we didn't have so much urgent start PD. We actually expanded the number of rooms that we had because we had so many patients coming in. And I'll tell you, it really improved relationships. When you can think differently and then have good outcomes, like the outcomes that we've been hearing about in the talk previous to mine, amazing outcomes. When you have outcomes like that, you start to open the eyes and the ears of other people. And that is hospital systems who want to hear that you can decrease length of stay. And you open the eyes of payers who hear that you can decrease the overall cost of care. And then maybe that opens up a conversation like we were able to have to get a peritoneal dialysis program opened up at a rehab center, which I've been trying for a decade to get open. So it is these integrative strategies and new thinking and new models that we need. And so with that, I will end. And again, I thank you so much for your attention and your time today.
Our next speaker is Dr. Michael Galicchio. Dr. Michael Galicchio was born in the Bronx and raised in Yonkers. He's done his BS-MD program at Albany Medical Center. He's trained in general surgery and transplant immunology at Albany Medical Center. He's completed a clinical transplant surgery fellowship at the University of Alabama in Birmingham. Dr. Galicchio is a board-certified general surgeon and a fellow of the American College of Surgeons. He's held academic and clinical roles in transplant and vascular access surgery at Albany Medical Center and the University of Alabama. He is a founding member of the Vascular Access Society of the Americas. He has extensively published and lectured internationally and nationally. He is a co-founding person for the Dialysis Access Institute in South Carolina, and he returned to New York in 2017 to join Capital District Renal Physicians. He's going to be talking to us today about surgical placement, best demonstrated practices. Welcome.
Thank you for that wonderful introduction, and I greatly appreciate the opportunity to speak to you all. I promise I'll make up whatever time was lost by Vince, because I speak even faster than he does. And are there any surgeons in the auditorium? Kind of thought maybe that might be the case. I was hoping Anil Hingorani would have made it, because Anil is actually a classmate of mine. Both for college and medical school. We were in the same program. I will be speaking on the technique that Vince had me try to develop. I even brought props. I was going to bring a deck of cards and do card tricks, but he asked me not to do that today. It's called the seamless technique. It's actually a modified open technique. It can be done, I believe, by any trained general surgeon who does peritoneal dialysis. Honest. For the selection, it can be anybody. Anybody that you're going to place a peritoneal dialysis catheter within can also have this seamless type catheter. The more intra-abdominal surgeries they've had, the more I would recommend that they undergo a modified laparoscopic technique just to make sure that you're not blindly placing the catheter in a position that you don't want. But it can be done in just about anybody, particularly anybody who can undergo general anesthesia. There are ways to do it under monitored anesthesia care, but it becomes more difficult when you make them more complex. I would recommend putting them completely to sleep and being able to put it in so you get the complete muscle relaxation, because the muscle splitting technique is a very important facet to this operation. In my hands, I don't need to stop any anticoagulation. It seems that everybody is on Eliquis or Coumadin these days, or at least Plavix as a form of aspirin therapy. And I don't stop any of them. It's not necessary. I'm not going to show you all the videos. This talk technically is more involved surgically, but we'll keep moving. The incision itself is done in the mid-abdomen, the lower paramedian periumbilical region. You want to utilize a paramedian approach because you can actually make a muscle splitting through the rectus muscle, and doing that muscle splitting technique is actually important. There's also the further lateral you get from the true midline, you get away from the preperitoneal fat in the midline, and I've got a great slide at the end of the talk to show you what I'm talking about. The posterior sheath fascia in just about everybody, not everybody, but just about everybody is tough enough that it will hold suture, particularly to be able to put in the purse string. And if you stay above the linea semilunaris of the low abdomen pelvis, you're going to find some good fascia. And again, I've got a great recent picture to kind of go along with that. As you can see in these slides, what I've done is I've cut down onto the anterior rectus sheath. That's the white line that you can see. And then I separate the anterior rectus sheath with cautery, go down onto the muscle, separate the muscle, and you can do this bluntly in generally an avascular plane. However, even if you have some oozing or bleeding, again, many people are on anticoagulation, you can cauterize that muscle with relative impunity. And since you're not going too far lateral, you're not going to get into the inferior epigastric vasculature. I open the fascia. I'm going to go back. Hopefully it's not. Yeah, there we go. I open the fascia at the very inferior-most aspect, and that's the posterior sheath, at the inferior-most aspect of the incision that I make. I actually make a relatively long opening in the muscle, and that's so that the catheter seats well. That is one of the very big keys to this. The failings of the Covidian Missouri catheter in how it was developed are myriad. My technique overcomes those failings. This is the catheter. This catheter has been available for many years, 20, 30 years. It's fallen out of favor, one, because it's poorly designed, and two, everybody wants to put it in laparoscopically, that's peritoneal dialysis catheters, and that doesn't fit through a laparoscopic port easily, and it's really just in the way. That's why everyone uses a Tenkoff catheter. The problem is, a Tenkoff catheter does not seal appropriately to get a watertight seal immediately. That will allow you to do it. But the way they designed it is, anybody here from Covidian? Good, stupid. Okay. I've overcome the failings. I'm glad that I was able to do that. That's why I developed this, and that's what took the time that I needed for Vince to answer, that I kind of answered immediately, but I came back to him after a day. When you orient the catheter, and you have to understand, imagine this is the patient's abdomen. The recommendation is that you orient it so that you put the catheter in and then you deal with this preformed bend and you bring the catheter out. Except anybody here who performs dialysis and has had a Missouri catheter, and its redheaded stepchild brother, the Toronto catheter, knows that these catheters tend to migrate. They don't stay down in the pelvis. And the reason this doesn't want to stay down in the pelvis is the way it was designed is it's supposed to stay in the mid-abdomen. So the first method of filling the belly full of fluid and then having some peristalsis, and the thing that supposedly is sitting like this is now sitting in the mid-abdomen. A peritoneal dialysis catheter sitting in the mid-abdomen doesn't work. Well, not technically doesn't work. It fills, but it doesn't drain, which is the first phone call I'm going to get. And if they're not constipated, then I got to fix it. So I never really liked this catheter because I would get the phone calls about other people putting this catheter in, and invariably I would have to fix it. And I figured out ways of doing that with tacking procedures and everything else. But I realized the failing is the way they think that that little angle, and there's really an angle there, that little angle will be sufficient to go in and turn it. And then I just turned it like this. I said, well, this is the way it should sit. Have it sit on the peritoneum like so, and just have it come out like this, and that catheter is going to want to stay in the pelvis the whole time. That was the idea. So I orient it appropriately. I put my stringer through. I guide it down. That's how it works. Then I hold up the purse string, and I'm really careful about setting it because, again, it's not really easy to put a purse string right there. Excuse me. I don't want to deafen you as much as I'm deaf. So we want it. This is also poorly placed, the way this flange is sitting there. Again, I wish someone was from Covidian here. And ultimately, we get to the point where I thread the catheter in, and I use the picture on your right. That's a catheter that was in for many months, who the patient was having some pelvic pain, and I said, okay, I'll fix it. And I don't know if you can see, and I know that he had said there's a way of using the laser pointer. There's actually a tacking stitch right there. That's the stitch I did to tack it up. But I got lucky. She had an adhesion that we didn't know about, and I actually threaded it beyond the adhesion. Just pulling it up just slightly like that was enough to fix the problem that she was experiencing. The picture on the left, as you look at it, is the whole key to this. I have the muscle split. You can see my finger pushing down, and what you really see, as you can see on the right, is that 1.5 inches or so from here to here. That's now, I'm pushing the catheter down so it's sitting like such. And by doing that, that makes the catheter want to stay down towards the pelvis and stay there as much of all the time as possible. By doing that and then closing the fascia over it, the catheter wants to stay in the pelvis. And that's what you need when you say, yes, it's immediate use. Because a catheter that you have to fix isn't immediate use. So I did the purse string, I've got the catheter in, and now I'm going to close. And I came up with whatever watertight solution I could come up with. I actually use skin glue on sutures that I run in the skin just because I do. The other thing is, drainage is still a problem because it's concerning. And a lot of these patients have anasarca. So they're going to drain from holes that you puncture in their body. And they're going to leak fluid. And the way you can tell that it's actually not PD fluid is by doing a glucose test on it. But the bottom line is you want to try to not have it leak. So I'll seal the skin incision, which is the largest thing, with skin glue along with a running whip stitch. The exit site, I've considered placing a purse string, much like I put a purse string on exit sites of hemodialysis catheters, but I just don't like the idea of putting that foreign body right there, even if it's an absorbable stitch. But the catheter sits very well, and it seems like when you put this in correctly, it's very elegant in the way that it seems like it wants to be that way. And that's it. Closing the fascia over it. One of the things that I'm a very particular person about is that I close the fascia above and below in a way to make sure, because fascia heals by necrosis and then scarring, and I don't want any more gap than necessary. It's just a surgical technique that I employ that I learned when I was doing ureteroneocystostomies with using the Minnesota one stitch. Okay. You develop a second pocket, you bring it out, catheter exit site, and it doesn't leak. The average amount of time it takes to put this in is about 40 minutes. We do them laparoscopically because we can do them very quickly. Average amount of time is probably about 15, 20 minutes when you do them laparoscopically. This is not particularly different. I mean, it is longer, but we've placed open catheters many years before we had laparoscopes. This is doable. This is a catheter that you can get on a shelf anytime. It just has to be put in right. Now here's what's kind of the cool picture. This is, as Admiral Akbar would say, it's a trap. All right. Here's your pelvis, there's the pelvic wings. You can actually see the inferior epigastric vessels here, so you got plenty of space. You can actually see how thin, almost transparent, the fascia there is, but this fascia looks actually white, so it's got more integrity. However, this individual has these large paramedian fat pads, and that's where you'd be kind of wandering through, and I've got to wonder how good the fascia would be right there. This is the guy that I'm waiting to encounter on the open side, where I'm going to have to go through some fat, I'm going to have to go through some thin fascia, and we'll see whether or not that tests the integrity of my statement that I've put over 100 of these and with no leaks. And we'll see whether or not this will be the first person who I leak or have a leak on. But right now, no leaks. Thank you so much. I appreciate your time. I hope you found it at least slightly informative, but hopefully more so entertaining.
Thank you, Dr. Laccio. Would I kindly request the speakers, Andrew Beaumont, Vince Carcello, and Michael Galascio, to have a seat here. This is the opportunity for audience to, and Dr. Salifu, do you want to come up to start the Q&A for this session?
Thank you to our speakers. That was a wonderful session and covered a lot of grounds following the first spectacular keynote speech. So we are open to questions now. Any questions for our speakers? Yes.
Thank you. I just asked if with the open technique for the catheter placement, if you have a increased risk in patients having hernias post-op.
Zero.
Okay.
Zero. When you're closing the posterior sheath, which isn't the layer for strength, that's the seal that you need so you don't leak. But the anterior sheath is closed just like any other layer, and I close it interrupted, but I make sure that I close both sides so that I seal the exit site the best way possible. So I've had no hernias there, and I've had no... Okay. I kind of figured, yeah. My wife says the same thing in 3 rooms away. So the answer is zero. No hernias, no increased risk. It's a bigger incision. That's the one thing you have to tell people. I tell people it's a modified open technique because it is an open technique and it's a real catheter that is generically purchased. I just tell them how I use it. And in fact, I'll frequently show them the difference between the catheters and what I'm going to do.
And Andrew, I have a question.
You have a question, Dr. Sagi, go ahead.
Yeah. Sorry. In your model of transition and increasing patients on home therapies, you did show one critical element of social workers. And my thing is in using the outpatient setting, social workers are not funded, not paid, etc. How were you able to get social worker involvement upfront? You want to comment on that?
So we're lucky enough at our program that we always had a social worker there and to do other functions. Who was there, well, always to provide care. It's something that our institute has always funded, but not reimbursable. We've talked about doing it in other ways where we would, you know, one thing about our institute is we, unlike many dialysis units, we have a combined chronic nephrology practice along with dialysis units. So we're perfect, you know, we're better situated to help with transitions. But within that model, using dialysis social workers for CKD, you know, kind of, in part, giving people more work is part of the answer. But hopefully, you know, these things can be reimbursable at a certain point.
So my question is regarding the PEAK program also. I mean, on one of your slides, it showed that in 2019, you had that really great peak in your home programs. I'm just wondering, did, you know, Trump's executive order, and in particular like that ETC model, did that contribute? Because it would show that it actually worked, and now that the ETC model is, the program CMS had is, it's ended, how do you intend to, you know, continue that process, again, because your program seems to be working so well?
Right. So we preceded those models, and we're never really, our model was, we're never exactly motivated by them. If anything, we felt we added to the discussion that to help develop the models, you know, in a more general way. So I don't think the impact of any, and we've also decided not to take part in something like the KCC model. So it's not going to directly impact what we're doing. But ultimately, for it to be applied across the country, you need some type of payment model for most programs.
Dr. Salifu, there are two questions on the chat, and I apologize because this is being broadcasted live. For the first speaker, there were some questions which I will email him to answer, so my apologies. And so this kind lady, can you tell them the question?
From the chat, okay.
Good morning. So the first question for Dr. Bailey, is he in here? Okay, so the first question.
Yeah, he can come up.
From our Zoom.
Dr. Bailey, if you don't mind.
Okay.
He's still here, yeah. Go ahead.
Abiade on Zoom wanted to know, how have you been maintaining good retention in the DPP program?
What is it?
Abiade from Zoom, can you hear me?
Can you read the question again, clearly?
Read the question again.
How have you been maintaining good retention in the DPP program?
One of the real challenges of the way the DPP program is paid, there's strong incentive to keep people engaged for 1 year in the program with regular meetings across a year. I think it's like 14 sessions. It's a lot to get people to sign up for. The short answer is relationship. What we've discovered is that the reason people come back, and we've had very good retention, is because they really enjoy the relationship with both their coach and their support group. You know, and really we frame the DPP program as more of a support group where there's mutual and shared advice and coaching. And we think that relationship, much as you described, you know, with some of your programs, that's what keeps people engaged and coming back, is that they're actually looking forward to seeing and value the participation with fellow clients and their support team.
There's one more question. Thank you, Dr. Bailey.
So we have a question from Victoria on Zoom. Her question is, how can we get more surgeons trained in PD catheter placement? Especially this technique also, is there any incentive to get more surgeons to do this?
I actually freely share the slides that I have present, and I'm willing to speak with any surgeon who's interested and even describe how the surgery is done in particular detail. I truly do not believe that this is a particularly complex operation. I believe anybody who is general surgery trained would be able to do this in their practice. The slides that I have there, I have shared with people. I have sent pictures. My phone is on 24/7, and I've taken calls anytime, anywhere from people who I've actually instructed on how to do this. Thankfully, I'm not the only one who's put these in, though I know I've put in the most. I know of a few surgeons who have actually tried to employ this. But it takes a multidisciplinary approach to actually optimize the whole process to make it the seamless kind of therapy. But the surgery, again, these slides are not doctored. These slides are not AI. These slides are very, very straightforward, and the technique is very straightforward.
Thank you, Dr. Galicia. There's one last question on the chat, and then we'll go back to the audience.
Permilia on Zoom would like to know the differences between Tenkoff and Missouri catheters.
So the Tenkoff catheter is double cuffed generally. That's what most people use. But the cuff is just one of the Velcro cuffs. The Velcro cuff like that, there are two of them. So that Velcro cuff doesn't seal and moves. I know many surgeons say, well, I have a technique that I use a Tenkoff and I get a watertight seal, and then I ask them, well, how many have you done and how many have leaked? And then usually I get a little bit of a hesitance in an answer, meaning they've not tried it. Now, some of it might be a relative lack of willingness for the unit to do so, because that's why we had to have the buy-in. I couldn't have just come up with this idea without Vince's support. And that first person, that was an interesting phone call, because Vince called me and said, hey, what do we do? And I figured what they did was they were still worried, and they actually laid her flat. So all the fluid was sitting outside her abdomen, and I don't even know if they put in 2 liters, but I knew that if I sat her up, that would be the proof in the pudding as to whether or not the catheter would work and whether or not it would leak. And that was when we were crossing the Rubicon. That working actually convinced the patient that it worked, but more so it convinced the dialysis unit. And now the dialysis units look forward to it because they know it works. But the Tenkoff catheter is 2 of these cuffs, and it's very different than that. But you can get that cuff through a laparoscopic port without any issue, and that's why everybody puts them in laparoscopically. That was a long-winded way of answering the question. I hope it did.
Thank you.
I have a question to just continue the conversation. This is for Dr. Casio. Did you see any differences in the way your partners, other nephrologists, actually approach PD? In other words, I know your enthusiasm is very high and you're probably pushing the boundary, But did you see your other partners doing the same thing? Because your numbers are really very good. Was there variation in how, the doctors actually behaved?
That's a great question. And like a lot of things that we've done that were relatively new, and I'm sure this is the case in most groups, we're slow to get momentum. And so not everybody's sure that they want a part of something new. Not everybody's sure. But what we did see is we're starting to see some specialization within the group. People who have different passions are being referred patients within the group. That is glomerular disease, and for me, peritoneal dialysis. So I started to see a lot of inter-office referrals for late-stage CKD patients for this. And we saw the same thing with the value-based care system, that clinical algorithms were a little bit different, and so sometimes it takes experience, just like it takes in a lot of areas of medicine, whether it's a new medication or a new program or just a new approach.
This is a follow-up question to that. So if a nephrologist who's not part of your group refers a patient to your program, and then you're able to eventually start the PD, what happens to the patient? The patient goes back to their primary nephrologist, or they stay with you?
We've been so pleased with what we've been able to do for our population, and we do have good working relationships with other nephrology groups in the area. So we've gotten referrals from those groups specifically for seamless catheters, and we send them back, and it's kind of improved our collegial relationships with those groups. It's nice to see patients flowing back and forth without the traditional anxieties of stealing patients and that kind of thing.
Right.
So it's actually been a pleasure.
An example of it's a little cherry picking, but there's an example of a patient who was not our patient. This was a woman who had bilateral lung transplants, was on peritoneal dialysis, ended up getting cholecystitis. She had her gallbladder taken out and had her PD catheter removed. Then she developed intractable ascites because she also had some cirrhotic changes of her liver. And she's also hypotensive, baseline blood pressure around 80, and trying to do hemodialysis with a perm cath. The doctor, who's not part of our group, said, well, see what you can do. And I said, okay, and I talked him through it, and I talked her through it, and I put a seamless in. I tapped off a bit of the ascites at the time, but I knew that her belly had already distended because she'd been on PD before,
Right.
that it wouldn't be pressurized as badly. So I knew that if I got enough fluid off, they could put fluid in and then start exchanging her and drain her. And I put it in. She was on immunosuppression. She was on anticoagulation. She was relatively cachectic. And it didn't leak, and she did PD.
Interesting. Very nice. This is a comment for Dr. Beaumont. It's about, and I think Dr. Sagi brought it up, how do we actually reimburse social workers and all that stuff. The CMS actually came up with 2 codes last year, January 2024, and they were now able, they produced 2 codes that can pay for patient education in clinics. So you're aware of that? Okay. All right. Okay. So I just wanted to make a comment on that. So if anyone is aware of those codes, and then you have patient education activities, those activities can be billed by a number of minutes, 20 minutes or 30 minutes interactions. They are billable activities in the clinic. But that came last year. We didn't have that before. So I just want to mention that as well. Okay. I think any other questions?
Anybody has any more questions? I just have one last question.
Okay,
Dr.
please.
Sarkar,
Yeah.
then
We
we'll
have
break-
time
break
before
for
lunch. Yeah.
lunch. And I wanted to ask Dr. Kalichi about the OR time availability, because I know this is an issue with scheduling, and let's say it's late, and OR says you won't have time today, tomorrow, because we're booked. How do you play that game in real life?
So, at the time of the initiation, this was pre-COVID, my OR in the one hospital I was working at, which got closed down for COVID, I was operating 4 days a week and office 1 day a week. What I can do is, this is my priority. I'm not doing anything else. So I would just add the case on, and the OR is actually very accommodating to me, and anesthesia, as long as there's a cardiac clearance, is very accommodating to me. So I just do it. I have two now, currently, after they closed the one hospital down, I have 2 OR days, I have 1 wild card day, and I have 2 office days. But my office days, I can add cases on at the end of the day, and the wild card day I can do, and I have 2 OR days that I can just add it on to my regular OR schedule. So I can always find time because I'm not doing anything else. I'm an access surgeon for this group. It's my priority. When I first started there, that was pretty much the thing that amazed them. They would call me up and say, "Can you see this patient tomorrow?" And I go, "Yeah." And they're like, "Really?" I'm like, "No, I'm lying to you." This was my job. It was my priority. I'm not a general surgeon who dabbles in it. I'm not a vascular surgeon who dabbles in it. This is literally my priority. And that's what made this a very good working relationship, because my priority is getting my patients seen, because I view them as my patients. They're part of our practice. So you get it done that way.
Yes, I'm happy to hear that, because you did have
It's
a
a
voice.
commitment, yeah.
Yes, yeah. And so just one last, what I'm seeing also, the support of the leadership who's leading this, and the patient's voice as directing things be done, right? So I'm happy about that. I think that's my last comment. So.
All right, so just to summarize the session, we had Dr. Boma talk about the PEAK program. This is basically transitions of care. And I think the model from Rogerson is just phenomenal. I wish every dialysis program was in that same model that Rogerson has, combining the doctors being able to combine the CKD, ESRD in a seamless, integrated fashion as they do it at Rogerson. And I'm very familiar with Rogerson, by the way. So that was the talk, how to make sure that our patients are actually getting this seamless care that is going through the entire process of care coordination and management, patient education, until they make the right choices. And you understand that it's actually possible to go from 2.5% home dialysis rate to 19%. That is just remarkable. That's like several hundredfold increase in the number of patients going to home dialysis compared to the traditional. So this is just a lesson for all of us. I'm sure if we did it in a way that is even approaching 50% of what you're doing, we will get 10% as an example. It may not be 90%, but it could be 10%, which is still good enough. So it's a lesson for all of us, and also thank you. And then we also learned about the seamless PD. There's urgent start, but this is different from the urgent start. This is really seamless. In other words, seamless simply means seamless, right? In other words, it's just seamless. There are no leaks, no nothing. You can do your dialysis almost immediately, and then the patient is happy. And someone mentioned the 3 happy. Happy patients, happy doctors, and happy somebody else. It was just a happy day for everybody, right? So that is really good. So seamless is seamless. So to be able to achieve this with a surgeon who is really, his commitment is just vascular access for ESRD, this is really phenomenal. So that's also another good model that we can pick and then use for whoever's listening now and through the Zoom. And we also heard about this from the surgeon, same group, so that's good. And then from our keynote speaker, it all starts from making sure we don't have this problem in the first place. It all just starts from there. And understanding what to do to keep healthy instead of what to do to be a hero. And I always tell the fellows, we don't want heroes in our systems, right? We just want to do the work, which means we can prevent disease, but we don't really pay attention to preventing disease. We spend so much time trying to treat sick people. So that was also another good lesson, and we learned a lot. the hubs, the neighborhood hubs, to make sure that patients have access for all this stuff to go on in terms of patient education and the motivational interviewing and empowering the patient and making the patient self-reflect and take ownership of their health. This is just phenomenal information that we got this morning as well. So thanks to all of you for bringing this to us, and for the audience and for those on Zoom. And hopefully we can put this in a book. Dr. Sagi has book ideas for all this, because it's so nice to have this, preventative approach to the transition approach to the surgical approach in the book format will just be phenomenal. He just talked about it when he came to the podium. So I just wanted to preempt you before he talks to you. So thanks for this session, and it's now time for lunch, and we'll regroup again.